This is where global expertise meets local ambition. Our distinguished panel brings together Dr. Brian Kennedy, Dr. Evelyne Bischof, Dr. John Newman, Dr. Mehmood and will be moderated by Martin O'Day. Together they'll explore what it will take to translate the science and insights we've heard into national strategies, clinical programs, and partnerships that can make Mauritius a model for the world. So please join me in welcoming today's panelists.
Hi everyone, how are you doing? My name is Martin O'Day. I come from the Longevity Summit in Dublin, and I'm very fortunate to have worked with Damien and Nadine for the last couple of months in supporting this event, which is brilliant. I think everything is looking great. They've done an excellent job, and I hope you enjoy the next couple of days. And I'm thrilled, honestly, to be here with this panel of really respected, esteemed gentlemen as we try to talk about the situation in Mauritius at a kind of high strategic level, what might happen here in the future. As John was just alluding to, maybe this is a test bed for the Longevity Nation. So if I know we've been introduced to Brian and to John and to Mehmood, so if I could ask Guy to maybe give us a couple of words about himself first,
okay,
if that's okay.
Thank you, Martin. Yes, I mean, some of you know me as a doctor, and I've been a doctor for a long time, and I've seen a lot of things in medicine, and I think that time has come to try and reduce our workload and try and look upstream and see, as all our famous guest speakers have said, we could do a lot in the future to try and slow down these processes. I have been interested in wellness, longevity, for the last 15 years. So when Nadine and Damien organized this so very nicely, she turned to me and said, Guy, I know you enjoy the subject and I think you want to do something. So maybe, if you don't mind, you can come, join us, and maybe be on a panel. So this is why I've been dragged into it. I'm here tonight.
And can I ask you first, the current situation in healthcare in Mauritius, is there a focus currently on prevention, or is it, as with most of the rest of the world, more a sick care than a healthcare paradigm?
Yes, I would say it's more sick care. There has been a trend, maybe a couple of years back, where you could hear in the radio where there were some policies where people should be exercising, doing more physical activities, and they were pushing for certain foods not to be allowed in schools. It was a lot to do with sort of primordial, mostly, rather than primary. But yes, there has been, at some stage, something started to happen. But I would say the bulk of the effort is still sick care, hospital care. I don't think there is anything in the hospital setup. I may be corrected by some of my colleagues here that targets primary prevention as such. I think it's mostly maybe in community centers they might have some things about it. I'm not sure. Yeah.
And I think what's fascinating about this event in terms of its mission, as well as the idea of looking at the potential for Mauritius's future, but also learning lessons from around the world. So if I could go to Brian, and just, I mean, Singapore, I believe, has the highest life expectancy in the world. Any insights as to how that's achieved, and anything that a place like Mauritius can learn or adapt or adopt even?
Yeah, I think that, it's been a long process in Singapore. When Singapore got its independence in, I think, 1965, plus or minus a year, I keep getting it wrong. But when they got their independence, they were, in a very undeveloped state. And Lee Kuan Yew, who was prime minister for a long time, really, I think most people would say, grabbed the country by the scruff of his neck and made a lot of changes that ultimately led to a much healthier and wealthy nation. I think that the last 2 decades or more, there's been a real focus on healthcare and first improving quote unquote sick care, but then on top of that, emphasizing primary prevention and healthier lifestyles, trying to make improvements to food and of course in the diet. And of course, it's not all the way done. There's you can still walk into 7-Eleven, and if you buy one of those cold teas, it's got enough sugar to like, they're good for long runs, but not for anything else.
Yeah.
And I think, so there are many changes that have to be made still, but I think the country has really made a commitment to the health of its population. And it's being reflected now in long lifespan and long health span.
And Mehmood, if I come to you, I know evolution is playing a role at a global level in terms of improving health span. Anything specifically you would see that Mauritius could implement now?
One of the things, and I think Brian touched on it, is what is it going to take? And we're talking about a public health national level, not at an individual level, and those are two different things. But as we look around the world, you'll actually see a common theme in this. One of those is have a clear vision at the top. What is it you want to achieve? And that's going to be relevant to your population. Taking on the United States is going to do, the UK isn't necessarily what Mauritius needs to do. I think Singapore took that clear vision. The second then is don't try and do everything at the same time. Mm-hmm. What we've seen is when people make mistakes, or large organizations or countries make mistakes, is a little bit of everything just to be able to check all the boxes. That's a huge mistake. You say, all right, if here's where we want to do, what's the first step in this? And be very clear what those are and how you're going to deliver them and all the rest of it. The third is implementation. If you get all of the vision right and everything else, it's all great, but who's going to implement this? Mm-hmm. How's it going to get implemented? How are you going to fund that implementation, which is where the focus comes in. And ultimately, one of the things that is interesting, and research shows us this, who are going to be the influencers? Because we're talking about human behavior in a lot of this. There's a very interesting research done back in the 70s and 80s in Chicago, and I think it lends itself to this, which is if you try to get diabetes education, which remember was the start of the diabetes growth in the US, the minority, in this case African American community, had a high burden. It was very difficult to get the community to engage. And the doctors did all of their stuff, and the pharmacists and the nurses and setting up diabetes centers and all the rest of it. It wasn't working. Simple experiment. They trained church pastors on the important ways of how to take care of yourself, to prevent getting diabetes, and if you have diabetes, how to take care of yourself. Guess who the most influential in that community? It wasn't doctors, it wasn't nurses, it wasn't your parents, and it was actually the church pastor. And they'd figured out in that community that the influencer, this is before social media, had a bigger say than the professional. I think there's a lesson there, which is who is going to be ultimately your partner in implementation and influencing this behavior to get the population where you need to go. So I think we can learn from things, and those are examples as we look across the world of some common things that have worked. Singapore has used many of these, but other communities have too.
That's very interesting. That's really interesting about the influencer, the pre-social media influencer. John, we were speaking backstage, and you were discussing the Neuroscience Educational Training Network, I believe. So I think one of the things for any region or nation that's trying to put its flag in the hold of longevity is how do you educate those that are going to be practicing. So I know a lot of your work is a crossover between the neuroscience and the geriatrician. So could you tell us a little bit about that network and about its potential for global reach, if you don't mind?
And I wasn't kidding when I said at the start of my talk that I really didn't learn anything about aging in medical school. And that's still often the case in medical schools in the US. There is such a need to teach all doctors, all nurses, all health professionals about aging as a concept, about aging biology also, and about how to apply what we learn about aging biology to the health of their patients. So how to address this is a really hard problem in a place like the United States, where there are hundreds of medical schools, and even if you can work your way into one of them and turn it into a fantastic institution for learning about aging, that only affects a tiny, tiny portion of doctors. I think one of the opportunities, talking about societal, government level, country level buy-in for change in a place like Mauritius, is that you might be able to reach all doctors, all nurses, and create an entire medical culture that's attuned to aging and aging research and geroscience and geromedicine. So I'm part of a national network in the United States called the Geroscience Education and Training Network that's trying to make this easier for medical schools across our country, but also around the world, by developing curricular materials to teach students, slides, courses, teach students about aging, teach students about geroscience, about aging biology, so that you don't have to have an expert in aging biology at your medical school in order to teach the students about that. We can provide you with the curricula to do it. And then one of the key gaps in implementation of everything we've been talking about is having clinician researchers, clinical researchers, not even necessarily clinicians, who know enough about aging, about studying older adults, and about general clinical research to do these sorts of studies. There are very few such people even in the United States. So the other goal of our network is to create training materials for people who are finishing their PhDs, who are in early stages of their medical training as fellows, who want to do research careers, want to do research in geroscience, to create the courses that they would need to learn what they need to know in order to run these sorts of clinical trials, and then provide those materials available globally to be able to be integrated into research training programs anywhere in the world, including in Mauritius.
And just add that I think it takes also creativity in how to implement this. If you go back to Singapore and look at about 80% of people go to polyclinics, and so these are these clinics you can go to anytime and you can get your checkup, or if you have issues. The doctor on average, we tried to integrate into those when we got there. The doctor on average has 8 minutes with the patient.
Yeah.
So even if they know something about longevity and lifestyle and geroprotectors, that's not going to come up in the first 8 minutes. The first 8 minutes is looking at the charts, coming up with a diagnosis, or talking about what risk factors they might have for disease. And there's no time. And so I think we've even thought a lot about how do you train other kinds of health professionals to spend some time with people in these polyclinics that are not doctors. They can talk about the geroscience and the lifestyle approaches. And so I think it's the structure of the healthcare system is also not conducive to prevention, and that needs to be thought about. So.
One of the great opportunities in a place like this, with involvement from the government and the entire healthcare system, what determines what a doctor does in those 8 minutes? It's mostly about what they'll be paid for in the United States, and what they'll be assessed for doing based on the quality measures, how you determine what good doctoring is. Those are somewhat arbitrary and are determined by other healthcare professionals. So is it more important to talk about when the colonoscopy was and what the A1C was instead of talking about aging risk factors, or should they be weighted equally? And those are decisions that a medical community can make. And maybe Mauritius is an opportunity to make different decisions than places like the United States right now about what's important.
So Brian, just to come back to what you were saying, because by the way, you stole my question. That was exactly what I was going to ask.
That was my goal.
I promise. But yeah, so I'm always saying, growing up in Ireland, you would not go to the doctor unless you were sick, because you felt like you were taking somebody's place who needed the doctor. And the doctors therefore wouldn't look at you until you were sick, because they felt they needed to treat people who were sick first. And while on a moment-by-moment basis that may make sense, at a societal level that's just nonsensical. Obviously, if you could prevent the illness, it's much more economic and better for everybody. So I know you said 8 minutes in Singapore, but can I go to the doctor in Singapore if I'm feeling fine? Like, what are the steps that they've taken towards improving health?
You can certainly do it for your annual checkup, but I don't know actually whether you can do it multiple times during the course of a year or not. I'm actually, I'm a PhD actually, so I don't know too much about it.
But you know everything about everything, Brian.
Yeah, but I think that you know, and of course, most people don't get their checkups. You know, that's another problem.
Yeah.
You know, I'll talk about a clinical chemistry-based aging clock tomorrow, and as you know, and it uses most of the things that go in an annual checkup. But
Yeah.
you know, most people don't have that data because they don't go do it unless they're starting to feel sick. So there's a huge educational issue here. I think also, though, you know, in a case where the government's paying for healthcare, or most of it, there are opportunities to say, all right, you get your health care, but only if you go get your checkups, you know, and so you can change how the structure of medicine is done in that way. So, and you save a lot of money doing it, so.
That's very interesting. I'll come in a second, Mehmood, but if I can just ask you about that in the Mauritian context. Can I go to the doctor in Mauritius if I'm not sick?
Oh yes, I mean, I think a lot of people visit their doctors, they're not necessarily sick. They go for checkups, they go for preventive screening. Yes, they do.
In private and public?
In private. You know, it's difficult to mix both because obviously the hospital has got a lot of work to do with sick people. I don't think they have time for healthy people, to be honest. But in the private, yes, I think there is quite a bit of screening and prevention.
In the public primary care? No?
Yes, maybe, yes.
And is this something...
It tends to be the community centres, as we call it.
And is that something that the government can pay the physicians for? If you want to turn, you know, like we were saying, is there a different reward system where the doctors are paid for having less sickness passed through
I think they have a system in Mauritius, which is, you're probably aware, it's called ICOPE, where they're supposed to visit people over the age of 60 at home once a month. I mean, you may say it's too young, 60, once a month is too frequent, but I mean, it's a good system if it was probably applied properly. But you know, as you said, Brian, you know, we've been trained as doctors. You know, I certainly had no idea that what was about to be talked tonight. 15 years ago, when I got interested in wellness, you know, I really thought that it's a shame. You know, why is it that it's only at the age of 60 that I have to be aware of wellness and longevity? I should have been taught this 50 years, well, 20 years ago. So I think it's difficult to mix healthcare, sick care, and healthcare. I just wondered whether we need to have hospitals and for people who are sick, and then maybe clinics that are longevity for people who are not only seeking for, you know, to see whether they are at risk or whether they should go for early screening. Yeah. Maybe we should separate both. I'm not sure, but I can see it that way. And then don't forget that public hospitals and private, it's a different business model. You know, if you tend to screen people for sickness, that's fine. Then we can get it back and treat it. But if you are to try and prevent people from getting sick, it goes a bit against the grain of the revenue stream. You know, I mean, it's a complicated thing.
So,
but, I mean,
sorry, Mehmood, aside from the potential to reframe the primary healthcare system, the reward mechanisms and everything, if people leave this event in 3 days' time, and again, an awful lot of time you go to conferences, there's an awful lot of really nice words said, but the follow-up and what happens thereafter. So with your kind of global strategic cap on, what do you think Mauritius could do to point itself out as a longevity nation, whatever that means, as a nation that's really focused on this 21st century industry?
Let me start with some learnings of what not to do. I've spoken over the years with many heads of state, prime ministers, presidents, and health ministers. The person that needs to be in the room that's often missing is the finance minister. And the reason I say that is, and I actually am on record in Germany, at Berlin, because the health minister was there. I says, you know, with all due respect, the health minister knows this is important. The challenge we have to understand first is, if you go to the finance minister and say, we need to do X, Y, and Z, and more of this, and more of this, the question in his mind, or her mind, is going to be, what do you want me to take away? Because the pie hasn't grown. So if you keep adding things, and you take that all the way down to an individual physician, and you say, you have 8 minutes to do this, and I want you, and I've practiced for 20 years, I want you to start doing all of this. It's going to end up being all of this added on top of everything else you're asking me to do. And then the reality of it is, what do you want me to prioritize, and what am I going to leave away? So I like to be empathetic to the person who we're trying to tell what they're going to do. Unless you end up with a very specialized niche practice, which is happening in the US, we call it, concierge practices. Now you've created a division, the haves and the have-nots. And that's a problem, right? So all of those, I think we have to understand in how to do it. And I think this is where somehow embracing technology to, I'm dating myself, in the old days, Brian, we used to call it, John, we used to call it physician extenders. And geriatrics is a field that does this very well, right? And so the question in this space, in my mind, at that level is, who are going to be the, quote, extension of this medical ecosystem? I don't like the term physician extender. They're part of this team, but it doesn't have to be the physician. And also, be careful not to have the physician be the driver of the policy. You have to figure this out in a way that says, okay, and so how much can be automated? What is the use of technology to be able to do that? How do you extend into the community? That is far more possible in Mauritius, given you've got a defined population. My guess is pretty well everybody can be identified, tracked into the system, given the size of the population, etc. And do this in an implementation which is very different than the traditional healthcare system, without just adding a list of things to do. This is a bit like, you go home at the end of the day and your spouse says, by the way, great day's work. Here's the 10 other things you haven't done, I want you to do them. Right? For anybody who's married in the room long enough will know what I'm talking about. But that's the key, and I think getting the right players on the table will choose. That is what Singapore got right to a large degree. And now is hitting the, how do I overcome the human capital hurdle, which just adds cost? This is not taking away jobs. This is supplementing.
Yeah.
No.
That's the term here is supplemented intelligence.
And
right?
as a matter of fact, I have more conversations with the Minister of Manpower and the Finance Minister than I do the Minister of Health.
Critical.
Yeah, because that's what they're thinking about. Not enough workers,
And by the way, finance ministers finally then will get it. Right? Where's my, and the other thing is, don't promise them, if you invest in all of this, we're going to save on expenses 20 years from now. Okay? Because A, he's not going to be the finance minister then, and B, nobody's ever given them an ROI. It's all a promise. You have to look at this and say, here's where the adjustment is. Maybe I'm talking like a CEO, but you know what?
You're allowed.
Those are the decisions you have to make in real time.
Yeah. So I'm just wondering, in terms of the global the holistic view of Mauritius then, because yes, you could look at the population level and how you make those governmental supported changes. But longevity, as it's kind of explained now, has this range of business opportunities as well. So for any one of you, is there an incentivization or an investment model that you've seen worked elsewhere in the world that might be of interest to business people and physicians and so on in the audience, and further afield in Mauritius, to take the momentum of this event and turn it into businesses?
Well, I thought your question wasn't for me. But,
for anyone.
No.
You said anybody.
But I mean, I have to be very basic, because Mauritius, we have to educate the people, because before incentivizing doctors, I think difficult for them to understand what is the benefit of exercise. I mean, I have patients coming to me and I say to them, you have to exercise, you have to move. You say, no, doctor, if I do too much, my heart will get sick and I will fail. There is a very complicated culture which has to be changed, I think. And then, food, good food is not cheap. So I think in Mauritius, there is a lot of emphasis put on oily stuff, sugary. We are a sugar-producing country, as you know. So there is subsidized food like flour and everything. So there is a lot of things to educate. We have a lot of availability of food, very accessible. I don't call it fast food. I call it super fast food because you could get it at any corner of the street. You can eat it walking around, and you can, there is no meal times in Mauritius. So this is, if you go on the basic lifestyle changes, I think this is where we should start.
Yeah.
Then even doctors, if you want to, I got educated myself by reading around. So I think doctors need to be educated. I think a lot of doctors here might say, well, maybe we're not talking medicine, we're talking maybe something we're not too clear about. So I think there is a lot of education that in Mauritius has to be done.
Yeah.
So maybe there should be centers, community centers for public people where informed doctors can go and talk to people. Maybe they can have mobile health kiosks, but I imagine that sort of thing.
Very
I think we
nice.
should go near the people because they don't move so much. They won't go unless they get sick. They won't move for health. They'll move for sickness, for sure. So I think this is something that can be done. Okay. And then, well, if you want to take it a bit further, if you want to bring a bit more hype into it, maybe we could make Mauritius a sort of wellness center where we can bring people from abroad. You're staying in a hotel and you can say, I'm staying here, then I can go elsewhere to get measured, and then I can get my wearable to... I think there is something. I mean, we have a great place. The air is good. We have nobody around us, no pollution as such. So I would go for that. Anyway, I hope I've answered your question.
It's a beautiful location.
Let me, if I may build, in this space broadly, if you put the investor lens on, you have 4 categories of businesses. Upstream, you have new technologies which essentially mostly played by either big corporations, pharma, diagnostic companies, or the venture world. The engine to that is new IP being generated. And the reality of it is, if you look globally, the center of gravity remains the United States for that, a little bit in the UK, the Golden Triangle, Switzerland, a little bit in the Netherlands. Singapore is trying, but there's not yet a track record of commercialization of that. So that is the reality of where we are. I think China remains a wild card because I think there's a future pipeline that's going to be large, given the scale of investments they've made. And similarly Japan, right? That's it. Very difficult for a new nation to suddenly say, I'm going to be generating that pipeline. The second is the ability to support the implementation either through capital markets, a unique regulatory environment, first to market, to generate. So there's a potential to play other than in the capital markets. You need to have large capital markets to do that. And even London in this life sciences from a capital market struggles. Singapore is not very risk prone as an example. So we've studied this across the world, and we can get into this in different ways. The third is there is a whole services sector, which is where Dr. Guy is getting at. And the reality of it is right now, the health spa where you come, change your lifestyle for 2 weeks, and then you go again, is being tried. There's no actual evidence that after you've left, you're going to continue on that behavior. And therefore, there's no evidence it makes any difference. And so this has become, this is the boot camp approach.
Yeah.
It's being experimented. I'm not judging that it is or it isn't. There's just no evidence yet.
Yeah.
India's tried this with Ayurveda. There's a whole variety of these. So we're yet to see, unless you do what Dr. Guy just suggested, which is you create an extension into the environment where you age. That is an extension into your everyday life. So this is induction, followed by some way of maintaining that. And technologists are now playing through connectivity, it's a whole variety. That's that sort of third category. The fourth category is this either what we lump it all under supplement, not regulated, non-regulatory environment, which is, it's a promise, but we're going to create online retail, a whole variety of these. And there is capital flowing into that, but it's either going to get regulated or there's going to be some form, and I will leave you with the example of just what we saw happen in Texas a week or two ago, which is a hackathon, biohackathon, infuse this peptide, infuse this. Guess what? 2 subjects who went to that got infused, ended up one on the intensive care unit, the other hospitalized because of the infusion. This is in the United States. Now, I don't care what the regulator says. I think the legal environment will sort that out very quickly in terms of what the scope's going to be, given the liability. So the field is playing with this in terms of, I hope that that's the landscape.
Yeah, no, I understand. Sorry, yeah. By the way, we're out of time, so we'll lean into it a little bit, but if you can keep it briefish.
My advice to entrepreneurs would be talk to clinicians to look at the gaps and opportunities, because healthcare is very expensive. And interventions, geroscience-based interventions that could reduce the need for certain types of expensive healthcare can be a real source of a market opportunity, and sometimes a very large market opportunity. Reducing length of stay in ICU, for example, through geroscience interventions that help people recover faster, could be a huge market opportunity. Reducing the need for long-term care because people emerge from their health crisis disabled. If you can prevent that with your products, huge market opportunity. And there are examples of this in the real world. Famously, the cure for hepatitis C, for example, was priced not based on the cost of manufacturing it, but in relation to the cost of the liver transplants that it could help prevent. And think about that framing when you're thinking about what opportunities there might be for application of geroscience type entrepreneurial activities.
I'm going to, because we're a couple of minutes over, I'm going to do a very quick, we've kind of covered this already, but a very quick, if we come back here, which I hope we do, in 2030, I hope we come back each year, by the way, but in 2030, 5 years from now, could you give like 1 or 2 things you think you would like to see in Mauritius for that event?
Yeah, I think first of all, I'm going to make a comment that's related but not directly answering your question. One thing I'd like to see here is a better understanding of what electronic health records look like, whether data can be accumulated in a large scale on people that are getting checkups, going to hospitals, and because there is a unique population here with unique cultural behavior, and I think one of the problems is and most of the ethnicities that are represented are underappreciated in aging research, and so we still have a lot we don't know. So that's one thing that could be very helpful. Something we've tried really hard to do in Singapore. But I think there has to be a mixture of sort of on the ground people that really are committed to trying to implement change, and maybe some expertise from abroad to help, and to try to come up with a plan that fits this country. It's very easy for us to show up in a new country and make a bunch of recommendations, but it doesn't work without an interest from the government or from the private sector or from somewhere we can come up with a committed plan that's going to lead to something that has durability in this country. And so that's where I think it should go. There has to be some, experts can always come in and say a bunch of things, but there has to be something going on the ground to really drive it. And maybe there is, I just don't know, but that needs to develop, I think.
Super. John, briefly.
In 5 years' time, I would love to see a conference agenda which is completely filled with Mauritian scientists and clinician researchers who are presenting the population-level data on intrinsic capacity and ICOPE tracking generated here in Mauritius. And there'll probably be pilot results, but the early pilot results of a series of geromedicine-guided interventions and how it affects health. And I think that's feasible in 5 years' time.
Amazing. Mehmood?
I'd actually build just slightly on that, which is, forget 2030, next year, let's hear from more people like Dr. Gee who are on the ground, case studies. We don't have to have, advanced science. Case studies experimented of what's working, what's not working. And importantly, this is not the world for Mauritius, but it's also what are the learnings from Mauritius that we can take away as experts to enrich our understanding, because that's a gap. to me, I believe in this two-directional exchange of information. We need more of that. I'd love to know what's working, what's not working.
In 5 years' time, you will be teaching us.
Yeah. And Guy, last thought, 2030?
Well, one thing I saw with Mehmood talk is that there's a lot of money spent in healthcare in the States, but it's not for that reason that they have a better longevity. So, I mean, if we look at our longevity in Mauritius, it's improved tremendously for the last 20, 25 years. And I think, medicine isn't going to change. It's not medicine, it's longevity medicine and neuroscience that's going to do the trick. Yeah. So I think there's hope for us. We don't need to spend that much money more and more into chasing up all sorts of pathology, which is very rare and in a very small, non-critical mass area. I think we should concentrate very badly on longevity science. I mean, this is a very deep thought, because, I mean, we need to be able to save money somehow in the future. Sorry, I'm talking politics maybe.
Can I apologize for going too long, but this is, I think you'll agree, it's an exceptional panel, so if we can give a round of applause for our four panelists. Thanks very much, guys. Thank you. Brian?